So thank you to the National Cancer Policy Forum Committee for inviting me. Sorry about this delay. So I was asked to speak to you today about oncology care pathways, the importance in relation to current EHR functionality and opportunity for improvement. As mentioned, I'm with Michigan Hematology Oncology, and we're an independent community oncology practice. Relevant for today's discussion, I think it's important to note that we, of course, have an EHR like all independent practices have, but we have multiple sites of practices, which means we have to interface with a number of other healthcare systems, of which everybody has their own EHR system. We do have a pathway program in place. It is, in fact, payer facing, and we are currently interfacing with a very large hospital system that's negotiating and implementing their own pathway program. I have no financial disclosures for this talk, and all opinions expressed by myself are solely my own and may not represent the opinions of the organizations, institutions, associations, groups, and boards which I am a member or hold a leadership position. So clinical pathways in oncology have actually been around for 20 plus years, and they used to be called and still are considered care management tools, usually used for decision-making when it comes to drug selection. But let's try to set the platform and talk about the definition of clinical pathways. Traditionally, they're a set of clinical decision support rules that utilizes a set of treatment recommendations that are based on high-level evidence, which aims to integrate the evidence regarding clinical efficacy, followed then by toxicity, and lastly, affordability of the treatments. The point of all of that is to create optimal standard of care recommendations for all patients while in fact reducing unnecessary variation of care that does occur across similarly situated patients. Thereby, the integration of clinical pathways then within a software tool can effectively and efficiently promote value-based decision-making. Value meaning not only controlling cost of care, but delivering high-quality care. Stated differently, the pathway outlines an evidence-based, cost-effective approach wherein the final decision should incorporate patient preference and clinical and social circumstances. So I'd like to discuss the next three slides are my vision, high-level vision of the value of pathways. As I had mentioned, pathways primarily have been care management tools that helps manage the decision with regards to drug selection. We do have some pathways that help with the genomics and diagnostic testing, as well as radiation oncology. But if we are truly going to achieve value-based care, then what we need is to have the provision of comprehensive high-quality care, cancer care along the entire cancer care continuum. In other words, pathways should help give advice in direct prevention, diagnosis, treatment, supportive care, and survivorship, as well as end-of-life care, assuring that we're doing the right thing for the right patient at the right time in both a cost-effective and patient-centric manner. This would include, of course, consideration for social determinants, patient preferences, their barriers to care, as well as provider and patient resources. The ASCO Pathways Task Force has, in fact, established criteria for high-quality clinical pathways in the areas of development, implementation, analysis, and this has previously been published. Specifically, as the criteria apply to the implementation, there was a call out to ease integration into the EHR and by further discussion into the workflow, for which would include reducing the administrative burden we often face with the institution of pathways, including pre-authorization. A second high-level value of pathways is to serve as an indirect knowledge management and education platform. As we can all appreciate, cancer care is becoming much more precise, and that scientific knowledge is growing exponentially. And in fact, the cancer care is becoming much more complicated. And in fact, that growing body of knowledge is immense, and it's not easily manageable. So pathways then can serve as a platform in assisting and educating the provider and the patient regarding appropriate interventions and decision pathways. And a third value of pathways has to do with empowerment, empowering value-based care and supporting the business models to do so by having the pathways collect and analyze data from their utilization, wherein value-based care encompasses not only financial performance, but also quality performance. Certainly in many of the congresses and meetings with regards to pathways, this is an overarching goal that all stakeholders wish to see accomplished. That includes the patient, the provider, the employer, and the payer. So then what are the barriers to achieving these goals from an EHR integration and functionality perspective? Well, certainly, I think many of us have already experienced that there's inconsistent integration into the EHR and practice workflow. And this is regardless of whether the pathway program is provider or payer facing, or if it's even relevant to the needs of the service organization. And it doesn't matter where you're located geographically. We all are experiencing these problems with integration. And I can speak to this personally, the common issues and barriers that we face with regards to the additional work that's related to this lack of integration. For example, I saw a patient today and I had to enter the data with regards to their staging in one EHR in terms of my record keeping. Then I had to jump out of that and go into navigating the pathway and putting that same information again. And similarly, in looking for clinical trials. So this interrupts the daily workflow. And then it lacks providing real-time patient care management recommendations. And oftentimes, not only in our practice, but I've heard many of my colleagues state that there's a delay of care. Another barrier has to do with cost. So the pathway purchase includes not just the implementation and the integration, but there's a maintenance of pathways that's required that includes technological upgrades and the assurance of optimal function within the EHR. And this can be absolutely prohibitive, and it adds to the overall cost of healthcare. You can imagine that there's oncology groups across the country of all different sizes, including very small groups that are barely able to make it day to day with their current budget. They cannot afford to add a pathway purchase and implementation integration because right now there is no reimbursement for pathway utilization, nor the IT costs associated with the integration of the upgrades. And furthermore, payers often use different pathways that adds more costs. It adds administrative time in terms of the implementation and operationalization of it and becomes very complex. A third barrier is that not all EHRs are created equal. We have EHRs out there that are quite old, but they're functional and they work. In fact, the word has been used, they're antiques. And as pathway vendors look then at the size of the installed base with both existing as well as prospective clients, they may favor more popular EHRs. Now that may be logical from an economic standpoint, but unfortunately it does create disparities in capabilities for practices and potentially different outcomes for patients then. So there we are with the variation of care. In addition, there's expense and disruption for upgrading EHR versions. In fact, in this last month, when we tried to upgrade our own EHR, we had several disruptions. And much less moving to a more technologically advanced EHR, there's costs. And again, as I mentioned earlier, this can be prohibitive for many practices. So what are the opportunities? Well, there are examples where there have been resources invested by both the EHR and pathway vendors to improve that data exchange and their interface and their integration. And there are examples of successful pathway integration, for example, in what I refer to as the homegrown programs, such as Dana-Farber and Moffitt. The disclaimer for this talk, however, is that this list is not comprehensive, and there are other examples that likely exist. But overall, the level of the EHR interoperability with other healthcare systems sorely lags behind other industries, and it's just insufficient. It does not support workflow efficiencies. And I can tell you from our own practice with multiple sites interacting with multiple healthcare systems, it's a real chore. And it interferes then with optimal patient care. How many times have I heard my patient ask, why can't your systems just talk to each other? So there are some industry standards that have emerged, but there is variability in EHR alignment to those standards, and the implementation has further confounded pathway vendors, who then have to build and maintain multiple interfaces with the multiple systems. Well, what does this result in? Inconsistent interfaces and higher costs. But this also strains the institutions and the practices who also have multiple sites that have to have these multiple interfaces. And finally, the EHRs are based on older yet effective and functional technologies, some of which, and they're not able to integrate with pathway vendors at all, thus representing more opportunity. So what are my 3 recommendations for my talk? First, policy should mandate that EHR vendors fully adhere to existing and new standards supporting full EHR interoperability with other healthcare systems. This would then encourage and incentivize both the vendors and the institutions, pathway vendors specifically, and the institutions to support integration and interfaces with EHR vendors that can support the most functionality with the least amount of resources. And when I use the word resources, that's a global term. It isn't just financial resources I'm speaking to. It's the IT, administrative, the physician and provider adaptation, and the training of the staff as well as the providers. Second recommendation, payers provide incentives in value-based shared savings models, which then in turn can be used to provide reimbursement and funding to support the technology and the integration pathway EHR functionality. So these financial incentives, however, would also include, not financially, but reduction in the administrative burdens that I just shared a very minor example with, including development of more efficient care plan approvals. And my final recommendation, any new care and payment models from CMS that promote the use of clinical pathways, which in my opinion, they should do so, should include technology incentive for practices to acquire, upgrade, and operate efficient EHR and pathway technologies. Thank you very much for your attention. I look forward to the panel discussion.
Thank you again, Dr. Zahn.